shukran, Dr. Najwa. Thank you so much, my colleague, for the nice invitation. And it's my pleasure always to be with you. So I was asked about the new frontier in the management of advanced renal cell carcinoma. Okay, the slide is not moving.
Doctor, just you need to double click the presentation so it can move.
Okay, sorry.
Yeah.
So the renal cell carcinoma, as you can see, it is not one of the top cancer in Saudi Arabia. And based on the last cancer history, it's almost 315 in both gender. However, Dr. Sultan Khatib from National Guard previously published data about in 2018 about the incidence of renal cell carcinoma that's increasing in Saudi Arabia, most likely due to early discovery with a new technology in terms of the radiological investigations. So if you see the NCC guideline in 2006, this is exactly what's looked like in metastatic renal cell carcinoma. If you have patient unresectable, just go for clinical trial or interferon or interleukin, which is both immunotherapy, and both of them have a very bad side effect, and the mortality with interleukin reaching up to 30%. However, now we have all of this plenty of medication in the first and second line, either in combination or as a monotherapy. And we are seeing now a tremendous change in paradigm of the treatment of metastatic renal cell carcinoma, from the initial treatment with the TKI of sunitinib, now the era of immunotherapy, and now we are in the era of immunotherapy plus targeted therapy. Now, also, if you see very important diagram here, which is called the memorial risk stratifications. And we know we are dividing the patient based on the prior nephrectomy, performance status, low hemoglobin, calcium, and LDH. And look for the pre-targeted therapy. This is pre-targeted therapy. Look for the good risk patient, the survival up to 20 months. And the median overall survival for intermediate risk, 10 months, and for the poor risk, 4 months. This is in the era of interleukin and interferon era. And look to the post-targeted therapy, almost double in the overall survival. This is post-TKI, and still we don't have yet more information about post-immunotherapy plus TKI. And as you can see later on, the overall survival is most of the trial does not reach. So we know that initially the trial of sunitinib was changing the practice at that time. Patient who has no previous treatment with excellent performance status, measurable disease, good intermediate risk, they were randomized to sunitinib and interferon by Dr. Mozart. This trial was published in New England Journal of Medicine and showed progression-free survival. As you can see, almost double from 5 months with interferon to 11 months. And subsequently, we have the pazopanib. It's identical trial exactly, and it showed again progression-free survival in favor of pazopanib compared to placebo. And subsequently, we have the COMPARE study when they compare pazopanib to sunitinib, and again by Dr. Mozart in phase 3 trial, New England Journal of Medicine, and was completely equal in the first line therapy in terms of progression-free survival with significant less fatigue and foot hand syndrome with pazopanib versus sunitinib. However, the major concern for this, there was no survival benefit. Only we are delaying the progression-free survival. And basically, we are dealing with a very harsh treatment. TKI is not smooth medication that we get. It's carry a lot of side effects, as everybody knows. So subsequently, the people, they were trying to look for the checkpoint inhibitor. And we know clearly now the checkpoint inhibitor, it's play a major therapeutic treatment option in lung and breast and name it, colon cancer, every tumor you can imagine. So based on that, the first trial was actually the emotion trial. And in the motion trial, they were looking for atezolizumab plus bevacizumab head-to-head with the sunitinib. It's again treatment naive, clear cell type, and patient. The primary endpoint was progression-free survival by investigators in PDL1 patient, and the double one was overall survival and intention to treat. Now, let's go and see the first table. When they look by investigator assessment point of view, it was showing there is a progression-free survival in PDL1 positive. However, it was not an intention to treat. This is investigator. And they consider the trial was positive based on this, this indicator. But when they look for independent radiological review, actually it was mild and there was no change in terms of progression-free survival benefits. And the concerning of this trial was only progression-free survival positive by investigator only, not by independent review, radiological review, and only in PDL1 positive, and there was no overall survival. And finally withdraw the submission and they remove it from the guideline. So atezolizumab plus bevacizumab in metastatic renal cell carcinoma, it's a history and should not be one of the options of treatment. So later on, we have a 3 important clinical trial, as you can see, and all of this was published in New England Journal of Medicine. Nivolumab plus avelumab versus sunitinib, Bempro plus ixatinib versus sunitinib, and avelumab plus ixatinib for versus again the standard of care, which is sunitinib. The CheckMate 214 again treatment naive advanced metastatic clear cell type. They were randomized to nivolumab plus avelumab. We give avelumab for 4 cycles and then stop nivolumab. We start with maintenance therapy head-to-head with the sunitinib. And the primary endpoint, they were looking for intermediate and poor risk patients, overall response rate, progression-free survival, and overall response rate. The CheckMate the CheckMate 214 showed progressive overall survival and with a very significant p-value favoring the combination treatment. And when they look for the intermediate, you can see the nice separation between the 2 arms with a very significant hazard ratio. Look to the hazard ratio of 0.66 and p-value of 0.0001. And the overall survival does not reach after almost 45 months. However, when they look for the favorable risk, there was no difference between the two. So immunotherapy doesn't seem it's good, and we are going to discuss this later on as choice of the therapy. And when they look for the overall survival by PDL1 expression, either high or low, both of them, they were benefit. However, those who has a PDL1 high, you can see the separation. It's a very nice, and look for the hazard ratio of 0.45 with a very significant p-value. And when they look for the progression-free survival for, again, intermediate and poor risk, you can see a very significant hazard ratio 0.77 with a p-value of 0.001 for intermediate and risk. However, it was not in the favorable risk. And again, the response rate was tremendous with combination therapy compared to monotherapy with the sunitinib. Now, the second important trial is the pembrolizumab plus ixatinib, again, immunotherapy checkpoint inhibitor plus TKI versus sunitinib, and is exactly identical eligibility criteria. And the primary endpoint was progression-free survival as well as overall survival. And as you can see, a very nice separation between the 2 arms. And a matter of fact, the hazard ratio of 0.53 with a very significant p-value. As you can see, 18-month rate is 82 compared to 72 with sunitinib. When they look for the progression-free survival, again, very significant, hazard ratio 0.69 and p-value of 0.001. What about the risk? Sorry. No, there's no one here. Okay, yes. So again, when they look for the objective response, you can see almost 60% compared to 35, doubled in favor of combination therapy. The third important trial is JAVELIN. Again, they compare avelumab plus ixatinib to sunitinib, and it's the same identical key eligibility criteria. And the primary endpoint was double with progression-free survival and overall survival. And as you can see, almost double a progression-free survival in PD-L1 positive patient with, again, significant p-value and hazard ratio. However, the overall survival still immature, and they were still waiting for the results. And again, if you look for the progression-free survival, regardless of patient PD-L1 positive group or overall population, both of them seem benefit from the combination regardless of the PD-L1 status. Just last week, we have a very important clinical trial adding more puzzle to our life, which is again nivolumab plus cabazitaxel. And remember, nivolumab was approved in second-line therapy post-TKI, which showed overall survival. And cabazitaxel, again, a TKI, approved both sunitinib or cabazitaxel in second-line therapy. And those combination and this two medication is the only medication showed overall survival as monotherapy in second-line setting. Now they move these two medication together as a combination versus sunitinib in the first-line therapy. It was done by Dr. Tony in the last ESMO, what's called 9ER. So basically, again, the same category of patient, previously untreated, clear cell, and they include all the patients. They were randomized to nivo plus cabo, head-to-head with the sunitinib. And the primary endpoint was progression-free survival. They were looking for overall secondary endpoints, overall survival, or response rate and safety profile. And look for the progression-free survival, how nicely is. It's almost doubled with a hazard ratio of 0.05 and a very significant p-value. And when they look for the overall survival, it was nicely separated. Nivo cabo overall survival does not reach for or intention to treat for the whole population. And again, the hazard ratio 0.60 with a very significant p-value. Doubling of objective response from 27 to 55 in favor of combination therapy. So we have a 5 regimen in the first line: metastatic renal cell carcinoma, atezo plus beva, avelumab plus ixatinib, pembro plus ixatinib, nivo plus avelumab, and nivo plus cabazitaxel. And the question, what we should do and how we can choose. Now, if you look for atezo and bevacizumab, it's out because only progression-free survival in patients based on the investigator assessment only. So it's an out of the comparison. And if you look for avelumab and ixatinib, still overall survival immature. But if you look for the other 3 regimen, all of those 3 showed an overall survival benefit. So if you look for the CheckMate 214, which is nivo plus AB, you can see they have the highest number of patients in clinical trial, almost 1,000 compared to 800 and compared to 650. Now, if we look for the risk fact or risk category, 23 were in CheckMate compared to 32 in the keynote, and 9ER 23 is a favorable risk, and majority actually was in intermediate and poor risk populations. And if you look for the PD-L1 positive, In the CheckMate and 9 ER, it's only 23 compared to 60% in Exatinib plus Bempro in Keynote 426. Now, if you look for the CheckMate compared to Keynote 426 and compared to the ER, all of these three showed an overall survival. All of these showed the progression-free survival. However, it was more striking in the ER9 and Keynote 426. And if you look for the overall response rate, all was in favor of the combination treatment. Now, look for the complete response and look for CheckMate was approaching to 10.5. Keynote was almost 9%. And combination therapy with ER9, it's 4%. Now look for grade 3 toxicity, which is the most important thing. It's an equation. You'd like to improve the survival, and you like to have an excellent quality of life. The grade 3 toxicity was 46% in CheckMate 214, and it was 63 almost in the Keynote 46. And 60%. So is immunotherapy plus TKI higher incidence than immunotherapy plus immunotherapy in terms of toxicity? Let's go for the rate of discontinuation of the treatment because of the side effect. It was 22% with both nivo-ipilimumab and almost 25.9 with the Bempro plus Exatinib and 15.3 with cabazitaxel plus nivolumab. So keep in your mind, cross-trial comparison is a very dangerous, and we should not do it. Different heterogeneous patient and different primary endpoint, and we cannot depend on this comparison in our judging of our treatment. So what I should do for treating my patient if he comes to my clinic tomorrow?
One more minute.
Oh, sorry. Very important to look for the memorial. If the patient have good risk, definitely there is no good rule for combination therapy, and the best option is still sunitinib. And this is basically because the angiogenesis is very low in patient with with poor and intermediate risk compared to the angiogenesis high in patient with favorable risk. The second important thing, the sarcomatoid feature, and we know carrying sarcomatoid in renal cell carcinoma, it's carrying worse prognosis. However, in all the important trial, it showed an overall survival with a combination therapy in terms of overall survival and progression-free survival. And non-clear cell type, we have the papillary, choroidic, and clearly immunotherapy play a good role on those category of patients. So the big question, shall we start with immunotherapy and immunotherapy combination or immunotherapy plus fast quantitative growth factor? And do we have any comparison between the two? There was a retrospective database and it showed there was no difference between the two. You can start whatever you like. This is how the NCC guideline, they include all the medication they throw it in the first line treatment. However, in my option of therapy for good risk, still sunitinib should be the standard of care. Until now, still we would like to see nivo plus cabazitaxel, a subsequent analysis of good risk. However, for intermediate poor, I think nivo plus EB, nivolumab, cabazitaxel, pembrolizumab, and exatinib, avelumab plus exatinib is still an option. So always keep in your mind decision for making. For me, I always look for, as a physician and healthcare provider, overall survival, progression-free survival, response rate, and for the patient, easy to use, safety, quality of life, and definitely the patient preference. This is a very excellent, but I think at the meantime, the most important thing is the price, and only price which is going to handle what's the best option in our therapy. And with this, I would like to conclude. Thank you so much.